I would like to stress when you are looking into a balance clinic is spend time with the patient. It is only time. You have to at least spend 30 minutes for each patient in evaluation. So if you have the patience, you will be able to control the dizziness. Thank you.
Thank you, sir. So, good afternoon, everyone. After a great lunch, Harsha, I must have cursed you twice or thrice for doing this program on December 1st. Had it been on December 8th, it would have been great. Because coming to Hyderabad and not eating biryani is a crime. For me, still Kartik Masam is existing, so I was not able to eat biryani. Tastier? That's what I'm missing it. I'll come next week also then. So, I know like the earlier BPPV is something interactive, some logical things are there. But coming on to vestibular migraine, this is little bit dry and more of hypothetical, and we need your brain to be present here. But I know after the great lunch there, I will try to keep you awake. Let me know whenever you feel bored. I will try to skip those things. So again, like all thanks to my teachers. And this is one person like whose books have inspired me a lot. Professor Adolfo Bronstein from UK. He's a neurophysician. And now we are dealing with this. What is this? Did you notice some interesting things in this? They're independent, changing the colors. Initially it was proposed to be camouflage, but later new theories were there regarding how it will change colors. So probably one entity in the entire medical fraternity which can mimic or which can be called as chameleon is the migraine, or you can simply, from our territory, we can call it as a vestibular migraine. So, how many of you think migraine means headache? How many of you think migraine means headache? Okay. How many of you think migraine means not headache? Not only headache. Migraine need not be associated with headache. The problem or the perception of migraine is the involvement of the International Classification Society for Headache Disorders in migraine. So usually the perception is migraine means headache, headache means migraine. Like there is a Telugu movie, time ante Kaushik, Kaushik ante time. In the same way, migraine ante like headache, headache ante migraine. But at least for the non-neurology people, neurophysicians are well versed with all those things. But now I would like to also emphasize here two things. The thing what we are trying to deal here is neurootology. That means teaching the neurological parts to the otologists. So there are now two subspecialties coming together, neuro-otologists and auto-neurologists. Neurologists learning otological part, otologists learning neurological part. You know this definition, very frequent, episodic, reversible primary disorder, characterized by head pain. Rather than that, this is the most important thing, autonomic dysfunction. It's a sensory processing disturbance. The next line states what is migraine. It's a maladaptive behavioral disorder or a maladaptive behavioral response to stress or stressors affecting a genetically determined threshold. So almost like 15 people are sitting in the front row. The worst trigger of migraine, particularly for the speakers, is this LED screen. I strongly hate these LED screens. Very potential trigger of migraine. So, 15 people might be sitting in the front row. Only 2 or 3 might be affected with migraine. What could be the cause? That bright light is stimulating migraine only in 2 or 3 people. I have been having severe headache. I have been having migraine since last 2 hours. I took a tablet now. So, this genetic predisposition is mandatory. The genetic predisposition has been well established in few conditions like FHM, familial hemiplegic migraine, where there are 3 variants, 1, 2, 3, corresponding to chromosomes number 19, 1 and 2. These are already well established. But there is a lot more to be like established or research in migraine. For the next 1 hour or whatever might be the time, whatever we are going to deal, initially I want to deal with migraine, then come into the vestibular migraine, because vestibular migraine is just a small part of migraine. We have vestibular migraine when the vestibular structures are involved centrally. You have retinal migraine, you have abdominal migraine, you have menstrual migraine. You name anything, you can add with migraine. So it is defined as a severe throbbing unilateral headache related to nausea, photophobia, phonophobia and vomiting. Sorry, this is actually photo and phonophobia. Typo error on the first line. It has arisen from the Greek terminology called hemicrania. Hemicrania means half. So, but is it mandatory that it should have only unilateral headache? No. Bilateral headache can also be present, particularly occipital headache. Moderate to severe throbbing pain, which worsens with exertion or with movement. I am not dealing any of the vestibular symptoms in this part. Can be traditionally classified into migraine with aura and migraine without aura, or even you can classify it as episodic migraine or a chronic migraine. So these are the criteria. Now what we are following is ICHD3. What I learned earlier was ICHD3 beta version, but now official ICHD3 is there. There is a lot of classification. For that you can just refer the ICHD website. And this is the main thing, without aura and with aura. There has to be 4 to 72 hours of headache. Within that period, minimum of 5 headache episodes should be there. It should be pulsatile, unilateral in location, throbbing or intense pain, and exacerbation of the headache with the routine activities, accompanied with vomiting, phonophobia, photophobia. With aura is minimum of 5 headaches, among which at least 2 episodes must be accompanied with an aura. What is the most common aura that accompanies migraine? Visual aura. Visual aura can be of 2 entities. Either it can be Positive phenomenon or negative phenomenon. Negative phenomenon means your vision is becoming very narrow, scotoma formation. Positive phenomenon is something like extraordinary lights and all, zigzag fashion lights, flashy light sort of thing. So as I have said, well documented genetic history with familial hemiplegic migraine. So there are three things that are already like classically described. One is FHM 1, 2 and 3. So FHM 1 is involved with CA-CNA1A gene. Remember this gene, this is very, very important for vestibular specialists. CA-CNA1A gene is with FHM. FHM is familial hemiplegic migraine, where you have motor symptom accompanied. The patient, because that aura will be, or the cortical spreading depression will be going through the motor area in the brain, so that the patient will experience motor disturbances. Hemiplegic, temporary, which is reversible. Now the CA-CNA1 gene, 1A gene is also important in other two classical vestibular disorders, that is episodic ataxia type 2 and spinocerebellar ataxia type 6. So this gene is that important that it is responsible for 3 vestibular disorders. And this is for a voltage gated calcium channel. A mutation in that can cause or can trigger migraine. Female sex hormone acts as a modifying factor. See, in all these presentations, the red indicates must remember and the highlighted things are to be remembered. So I have written this thing, CA-CNA1A gene is associated with episodic ataxia and spinocerebellar ataxia 6 also. So FHM type 2 is with sodium potassium ATPase channel in the cell membrane. Any mutation of that can lead to this. The clinical features can be epilepsy, recurrent coma, fever and mental retardation. And FHM3 is with voltage gated sodium channels in chromosome number 2. There are other monogenic conditions associated with migraine. Just at least know the names: MELAS, CADASIL, RVCL, HIH-RATL. These are other monogenic conditions where already the chromosomes or the location has been already well described. So this gives all the genetic information. I don't know whether it is clear to the there. It appears blurred to me because of the near thing. See, all these are the genes. CA-CNA1A gene, spinocerebellar ataxia. Again, no, this is episodic ataxia type 2, spinocerebellar ataxia type 6. All the genes are there here. If at all someone is pursuing some interesting things into the migraine or research into the migraine, this picture can be very helpful. So now what are the triggering factors for migraine? It can be fasting, changes in sleep. Most of the people will think that lack of sleep or deprivation of sleep is a trigger. Yes, obviously deprivation of sleep is a trigger, but to my surprise, you might be knowing, but to my surprise, there are 2 things which are in excess are also causing like migraine, or the migraine triggers. One is oversleep. Sleeping for more number of hours is also a trigger for migraine. Physical exercise, alcohol, any weather changes, psychological or physiological stress. So other triggering factors can be hormonal changes, particularly in females. Menstruation period, 3 to 4 days prior to that and 2 to 3 days post menstruation. This is the most volatile period for a female to have migraine. So the tantrums or the behavioral change during that period is earlier attributed to lack of estrogen and progesterone. But actually this is triggering the changes in the brain causing migraine. If someone is behaving abnormally during either your mother, wife, sister, someone, they will be so good for those 26 days or 24 days, 25 days. But that 4 days or 6 days of little abnormal behavior will be there. That is because of migraine. These are the foods that can trigger chocolate. Everyone's favorite ice cream nowadays is chocolate. This is one of the culprit for migraine. Citrus, dairy products, fatty foods and fried foods, coffee, tea, caffeinated beverages, monosodium glutamate, alcohol and gluten. All of us consume a lot of these things. But only in few people who are genetically predisposed, migraine will be triggered with these things. So these are the triggers. You can see all sorts of triggers, either food, genetically, physical, physiological and biochemical factors. So, what can be used as markers in migraine? One is insulin levels are higher in migraineurs. That's why usually migraineurs will be having, can anyone of you tell? Huh? Hypoglycemia? No. This indirectly affects, actually, they will be having hyperphagia. Food cravings will be there. And second thing is, if you take an MRI, in few of the people you will be having white matter hyperintensities. I will show you an MRI for that. Next, superoxide dismutase can act as a marker. They will be at a lower level. Cutaneous allodynia in chronic migraine. What do you mean by allodynia? A stimulus which is not supposed to be painful will become painful. Bah! That's the thing. It's not painful, but in migraineurs, it will be painful. That stimulus will be painful. And of course, matrix metalloproteases are also one of the actors. See, these are the white matter hyperintensities that you can see in a migrainous brain. Once you order MRI for something else, you will be seeing these sort of things. You ask those patients retrogradely, do you have a history of migraine, or is the patient fitting into migraine category? Yes. So most of the ENT surgeons who are reading Vertigo textbooks or Vertigo books might be knowing this great guy, Professor Thomas Brandt. So that concludes chapter 1. Hopefully, like, it's engaging, right? Yeah. Okay, now probably for the first time in the world, I can, with the privilege, I can say this thing. Functional anatomy of migraine. Nowhere I can find, I did not find the stuff for this or any prefixed PowerPoint or something like that, or literature for this. So I have gathered a lot of information because we are working on vestibular migraine, and there are a couple of research projects that we are doing at our hospital, like supraorbital nerve triggering causing changes in video nystagmography. That is one study that we are doing at our Asian ENT hospital. So he is my idol and my teacher, my mentor for neurootology from Johns Hopkins. He is the head of neurology, neuro-ophthalmology and neurootology at Johns Hopkins. So as you all know, the main culprit is the trigeminal nucleus. So we have, how many nucleus are there for trigeminal now? 3, only 3. 3 or 4? 4. There are 4 nuclei. Out of that, the important thing is this one. Trigeminocervical complex, or the spinal trigeminal nucleus uniting with C1 and C2, that forms the trigeminocervical complex. This plays a crucial role in the migraine pathogenesis. So here you can see here mesencephalic nucleus of trigeminal nerve, principal sensory nucleus, motor nucleus and the spinal trigeminal nucleus, 4 nucleus, mesencephalic, sensory, motor and spinal. Now, next interesting concept is the trigeminal system. What is the nerve supply for the blood vessels of the inner ear? Can any one of you tell? Internal auditory artery or cochlear artery, labyrinthine artery, that's the blood supply. What is the nerve supply for that? No, they are sensory, boss. They are sensory. So the autonomic signals to these things are being carried by the ophthalmic branch of the trigeminal nerve. The ophthalmic branch of the trigeminal nerve supplies the inner ear vascular supply. Whatever inner ear arteries are there, to that the ophthalmic branch of the trigeminal nerve supplies. So that's why in migraine, vascular event followed by chemical mediators can lead to abnormalities in the labyrinth. Perhaps 160 years or 170 years back, Prosper Meniere has diagnosed this Meniere's disease. Right? And even in the earlier lecture, Dr. Srinivas has said, in BPPV, semicircular canals are the affected organs, but they are not the culprits. The culprit is the utricle. What made the autoconia to dislodge from utricle and free floating and then coming into the semicircular canal? What could be the cause? This could be the cause. Reduced vascular supply leading to this thing. That's why vestibular migraine and BPPV can coexist or can be a precursor. In the same way, vestibular migraine with Meniere's disease. See what happens? See here. See, these are the meningeal joral vessels and intracerebral vessels. From there, the trigeminal afferents come from the geniculate ganglion or the trigeminal ganglion. And from there, they reach the spinal nucleus of the trigeminal nerve, where the spinal nucleus of the trigeminal nerve combines with the C1 and C2, forming a trigemino-cervical complex, TCC. From here, the input is going to all the way to the brainstem and hypothalamus, thalamus and to the cortex. So the trigeminal afferents reaching through the trigeminal ganglion, reaching to the TCC, trigemino-cervical complex, and from there ascending up. Through some inputs are being sent to the locus coeruleus, periaqueductal gray matter, and from there to the hypothalamus, thalamus, and to the cortex. This is the trigeminal cervical complex for you. The second order neurons from the trigemino-cervical complex ascends up through thalamocortical neurons and from there project to the diencephalic nuclei and the brainstem nuclei. So these are the important structures for studying about the migraine. One is the locus coeruleus. What is the other name for locus coeruleus? It's called the blue nucleus. Blue nucleus. periaqueductal gray matter, the cuneiform nuclei and the superior salivatory nuclei. The superior salivatory nuclei and the locus coeruleus are present in the pons area, pontine area, and the periaqueductal gray matter and the cuneiform nuclei are present in the mesencephalic area, that is in the midbrain. So this superior salivatory nucleus plays an important role in giving all the parasympathetic signals that arise secondary to migraine. So now what are the mediators? One can be CGRP, the calcitonin gene related peptide, and the second one is the PACAP. PACAP is pituitary adenylate cyclase activating polypeptide. So even the therapies for migraine are targeting these two. CGRP antagonists are right now in the market, and there is a lot of research on PACAP antagonists. So the CGRP is well studied actually, it's a potent vasodilator, and increased CGRP in migraineurs causes decrease in the descending inhibitory mechanisms, leads to migraine susceptibility in migraine. Apart from this, neurogenic inflammation has also been considered as one of the pathology. So these are the four important structures that I have said earlier. So in these things, the modulation can happen. It is where your triptans, somatriptan or whatever you are using, that can act. The ergot derivatives, ergotamine can act there, and CGRP antagonists, all the zeptans can act there. And one more important structure you need to remember is the parabrachial nucleus. This trigeminal system also have a parabrachial from there to the limbic system. So this is the parabrachial nucleus. And this parabrachial nucleus is divided into medial and lateral by line of Baxter and Olszewski. Olszewski, where do you ever heard about this name? No. What is the other name for PSP? Progressive supranuclear palsy. Those who are practicing Vertigo, progressive supranuclear palsy, we often see. So the other name for that is Steele-Richardson Olszewski syndrome. Next important thing to be learnt about is the hypothalamus. And of course there are a lot of nuclei. And the topic of the migraine is now around the world they are focusing on thalamus. Thalamus plays a crucial role in the pathogenesis of migraine. And of course the cortex. The cortex is more important for the aura phenomenon. If there is a depression to the occipital area, you will be having visual aura. If the cortical spreading depression is in the speech area, the patient can be having aphasia. If it is there in the sensory area, sensory disturbances can happen. If it is there in the motor strip area, familial hemiplegic migraine can happen. And finally, these are the structures and it is their importance. This picture is the gist of the entire lecture. So I made it short lectures only, so that I can stop wherever, you tell me, if you are feeling little bored or something like that, I will stop or I will take a break and will grow. Coming on to the migraine pathophysiology. So you have 4 stages in migraine. What is the first phase called as? Prodromal or premonitory phase. Second thing is the stage of aura. Third one is the headache phase, and fourth is the postdromal phase. So when do you call episodic migraine? Headaches for up to 14 days in a month, you can call it as episodic migraine. And if it is more than 15 days per month and at least 8 days should fulfill the criteria of migraine, then you can call it as chronic migraine, because it is important to differentiate episodic migraine from chronic migraine to treat the patient. So why the lecture is actually meant for vestibular migraine? Why are we dealing so much of migraine? Because vestibular migraine is a presentation of migraine in the ear, that's all. So you need to learn about migraine if you want to learn about vestibular migraine, or the myriad of symptoms that are presented in vestibular migraine are secondary to this. So these are the 4 phases of the migraine. So what are in the premonitory phase? Actually it starts before typical migraine headache, and it precedes almost all by 72 hours. So irritability, the food cravings, mood swings, fatigue, stiff neck and phonophobia can be there. All these are hypothalamic in origin. Hunger, the bright light or sleep deprivation also can trigger migraine. See, some slides will be repeating because to emphasize the importance of those things. And this is what happens in the premonitory phase. So you can see the multiple afferents carrying the parasympathetic signals to the superior salivatory nucleus. I don't know, like mouse is not seen. The superior salivatory nucleus here. These are the parasympathetic inputs to the superior salivatory nucleus. It triggers the trigeminal, thereby causing the neural reaction at the level of the meningeal blood vessels. So from the trigeminal system, the signals directly goes to hypothalamus and the brainstem, and also ultimately lands up in thalamus. This is an indirect pathway and directly goes to the thalamus also. So these converging signals provide a high and low set points for the allostatic load. What do you mean by allostatic load? It is the load with, simply to understand, it is the load the brain can handle. Actually, what is migraine basically? What is migraine? Have you ever thought? Whenever your body homeostasis is disturbed, particularly the brain's homeostasis is disturbed, you are not eating for 5 days, brain will show a sign of rebellism. That's migraine. If your hormones have for 25 days estrogen is very high, all of a sudden estrogen is down, the brain is showing a rebellious activity. You are not eating, you are not sleeping, you are under tremendous stress. To make you understand, "Arey boss, I am under tremendous stress, the brain is not working well," you have to understand that the presentation of that is the migraine. So the brain will be having, at all these areas will be having low and high set points. Beyond that, they can't tolerate. That is where the migraine can be triggered in predisposed candidates. So even in migraineurs, why do migraine triggers always does not trigger migraine? I am a migrainer. I have migraine. Most of you might be having migraine, but most of you might not have recognized that. That's the only thing. All of the times, these triggers won't elicit the symptoms in me. Why does it happen? Harsha has given me a task that, "Sir, you should be dealing with migraine and vestibular migraine." Vestibular migraine, I am very comfortable, very happy, super, being an otologist and neuro-otologist. But coming on to migraine, this involves the higher structures where I have to do a lot of reading, lot of research, lot of stress. But that stress never caused me migraine. Because the brainstem activities, it depends on the cyclical brainstem activity. If it is very high, the nociceptive signals are inhibited, thereby inhibiting the migraine attack. If the cyclical brainstem activity is very low, the migraine can be activated. But of late, since yesterday morning, whenever I am trying to comb my hair, I am feeling some tenderness over my scalp. That is a symptom of migraine, probably full-blown migraine. Today evening or tomorrow it can happen. That sensory change, most of you might have observed. All the days while combing the hair, nothing will happen. Whenever these triggers you are exposed, and after that, once you start combing your hair, you will feel some sort of different sensation or some painful sensation. The same comb. Most of us generally don't recognize that. Next is the aura phase. So aura is seen in 1/3 of the patients, and it is due to the cortical spreading depression. So the cortical spreading depression is a very slowly progressing wave of depolarization, around 2 to 6 millimeters per minute. And actually there are theories that it is also associated with the hyperemia followed by oligemia of that cortical area. That means initially lot of blood flow will be there, followed by vasoconstriction. That can cause the aura. And of course, extracellular potassium will be elevated in phases of aura. So, you can see the oligemia here. The aura has started here and propagating. Initially oligemia and hyperemia can happen. And coming on to the next phase is the headache phase. It is due to the activation of the trigeminal vascular pathway. So the entire theories right now are focusing on the trigeminal vascular pathway and the inflammatory spillage. Ultimately, this is causing an aseptic chemical meningitis, causing the release of CGRP. So, this we have read already, afferents from trigeminal ganglion, the skin, the paraspinal muscles and C1 and C2, landing on trigeminal cervical complex, from there going to the brainstem, thalamus, hypothalamus and cortex and basal ganglia, thereby causing the symptoms. So this is the triggering of pain via trigeminal-vascular system. Next is the CGRP signaling. So this release of CGRP here is the target for the treatment. So that's why like CGRP antagonists are, even the European Headache Association now have given a consensus that CGRP antagonists, like anti-CGRP antibodies, are the first line of treatment for migraine, in chronic migraine. And to summarize this is the thing. You have all the 4 phases, the prodromal phase, the aura phase, the headache phase and the postdromal phase. It's 3:30, probably just another. Now coming on to very quickly the vestibular migraine. Just a small video. Actually, this is a promotion of a goggle. Ray-Ban. If you think that it is red, it is turning to purple, purple to green, green to black. You give a color, it is changing. Okay. So this is how a vestibular migraine can also manifest. It can manifest as Meniere's disease. It can manifest as BPPV. BPPV, history wise, if it is like BPPV, and if you see the unclassical presentation of nystagmus in BPPV positional things, always please consider vestibular migraine. And I will tell that in vestibular mimics, migraine mimics. And the problem is, even after taking a long history and examining the patient, if you keep a diagnosis of vestibular migraine, most of the patients are not happy. The first question they ask is, "Doctor, I don't have migraine. Why are you diagnosing me with vestibular migraine?" So even in the history part, if you ask, "Have you ever had of headache?" Most of the times the answer is no. And these patients will present very discrete sort of symptoms. And most of the times it is still both underdiagnosed and misdiagnosed. Okay. And this is the criteria for the vestibular migraine. At least 5 episodes should be there. This is one. Point B is history of migraine should be there, either with or without aura. C is vestibular symptoms should be there. And what are the vestibular symptoms? These are the things. Along with the headache, you should be having photophobia, phonophobia, and the visual aura, and not better accounted for the other disorders. Now, but the problem is, if you see here in the Barney criteria, if you see vestibular symptoms intense enough to either interfere or prevent daily activities lasting 5 minutes to 72 hours is the one of the criteria for diagnosing vestibular migraine according to Barney Society. But the problem is, only in 30% these attacks will be lasting for minutes. In 30% it will be lasting for hours, and 30% they are lasting for days. Diagnosing these cases is not that difficult, honestly. But coming on to the next 10% or the residual 10%, the symptoms last only for seconds. Only for seconds. Episodic vertigo lasting for seconds. What is the first thing that comes into our thought? BPPV. Again, misdiagnosis. Then you need to ask, it's coming only for seconds. In the entire day, how many attacks are you having? I am having 10 to 15 attacks. Yes, now it is vestibular migraine. But these are usually spontaneous attacks most of the times. And of course, sometimes triggers also, head movement also can cause. And next is, see, these are the lapses in the Barney criteria. So which need to be ratified or rectified in future. And according to Barney criteria D, at least half of the episodes associated with headache, photophobia, phonophobia, and visual aura. So what happens is, you will ask, do you have photophobia, phonophobia, osmophobia, or visual auras, anything? Sir, I sometimes am like having photophobia. So now the dilemma is, can we diagnose it with vestibular migraine or not? Yes, you can. All the things need not be present, only one per episode. This episode, the patient might be having photophobia. Last time, it might be phonophobia. Earlier, it might be visual aura. They can change, and only one thing can be sufficient. Because vestibular migraine is a clinical diagnosis. You don't need any other investigation. Only to support it, okay. But it's classically a clinical, in the clinic you can do it. So not accounted for the other disorders. You have to rule out all other things before diagnosing the patient as vestibular migraine. So these are the key points. Vestibular migraine is a frequent condition in general headache and neurology clinics with growing interest in the last decades. Detailed analysis is essential to increase the sensitivity and guarantee correct treatment. Migraine patients with vestibular symptoms have more concomitant autonomic associations, or they can have inflammatory associations, or they can have connective tissue associations. So, I would like to call this migraine or vestibular migraine or migraine as a silent pandemic. If you count the population that are being affected with this, it will be many fold higher than the people got affected with COVID. Now, it's the most common cause of spontaneous episodic vertigo. And 1% of the normal population, they will be having vestibular migraine. And take home points, these are recurrent episodes of vertigo of unknown cause should be attributed to migraine. Whether headache is there or not. Recurrent episodes of vertigo of unknown origin. It is not fitting into any of the diagnosis. Vestibular migraine is your savior. Vestibular migraine should be included in differential diagnosis of every patient with unexplained dizziness. So, I have already shown this thing. I would fondly would call it as a chameleon in the of the vestibular disorders. The problem is the patients will be like telling very weird symptoms. I am pushed into a barrel, I am like pushed into a tunnel. They won't classically say I am feeling spinning or I am feeling dizzy. These patients never say like that. They give a very unclassical description. And the descriptions appear to be to the clinician like that of a psychiatric history. That's why most of these people are being labeled as functional dizziness or triple PD. Most of the patients are labeled as triple PD. For God's sake, triple PD is not that common. All these cases are vestibular migraine. Before labeling a patient as a psychiatric patient or a functional dizziness, please make sure you have excluded vestibular migraine. Most of you must have seen the picture Troy. You know the movie Troy, right? You remember this scene? I don't have sound here, but...
What say you now, sister? Will Troy still burn?
Are you able to hear?
Don't ask a question if you don't want an answer.
Well, Cassandra, is there an answer?
Are you able to hear the sound?
For 10 years, the Greeks will pillage our country, attack our gates. For 10 years, they will raid the southern shores, enslave our neighbors, fatten themselves on their butchered cattle, become rich with spoils, and our friends will flee here, and flee here, and flee here. Until these walls are packed with broken people. And our city is filled with sorrow, our streets flooded with tears, until there will not be one of us with food to eat, water to drink, or air to breathe.
Cassandra, enough!
The war will not be over until the curse is lifted. You all know it. Why can you not understand? Why do you not believe?
Because, child, we must not believe you. We cannot believe you.
Paris must die.
Stop her, father!
I cannot stop. I will not stop until you listen. Founder, please. You don't know what you say. I say the truth. Only the truth. But none of you have seen
Yeah.
what I see.
So she is Alexandra Cassandra. She can see the future, but the problem is whatever she says, people ignore it. This is because of the curse of Apollo. You remember the story, right? So in the same way, the vestibular migraine patients are pleading you, but you are simply labeling them as triple PD and just go to the psychiatrist. Please don't do that. And age of the patients affected, females, particularly perimenopausal age. Females who are migraineurs throughout their age groups, once they menopause, the migraine or the headache attacks are being replaced with the vestibular symptoms. This is one important thing that you need to take in the history. And second thing, men in third decade. I can see most of the population are in third decades. You are the most eligible candidates to have vestibular migraine. See, my menopause was one of the variables distinguishing vestibular migraine from other migraine phenotypes. So the frequency can occur, vestibular symptoms can occur any time before or during or after an attack, and also interictally also between two phases of migraine. The patient can be having vestibular symptoms. If you examine the patients for longer duration, 2 years, 3 years, every time the patient comes once in a month between the attacks and during the attacks, you do video nystagmography. Every time you will be finding different findings. Last time it was upbeat nystagmus, now it was downbeat nystagmus. Last time it was right beating nystagmus, now it was torsional nystagmus. So, and one more important point, migraine was the commonest cause for the combination of neck pain and vestibular symptoms. Please ask if the patient is not telling, are you experiencing any neck pain? The problem is most of the patients, if they have neck pain and vertigo, they simply attribute, even some general physicians also, they simply attribute it to be cervical vertigo, an entity that has never existed and will never exist. And the vestibular migraine patients as well as the migraine patients are more sensitive to certain stimuli. The visual symptoms stimulating motion sickness. And these are the most difficult candidates. I used to have a friend while I was doing my MBBS, and he was not diagnosed with migraine at that time, 2001 to 2006. Like, whenever we used to go to movies in Kakinada, action movies, every time after coming from even though the movie is super, he said, what a bad movie, I had a headache after this movie. The action movies where the sequences will be fast, zap, zap, zap. Even nowadays the music and few directors are also taking the same cuts, very fast cuts and very fast moving. These can also trigger headaches, or these can trigger a migraine. So what are the comorbid conditions these migraineurs or vestibular migraineurs can have? They can have BPPV, motion sickness, or even Meniere's disease. And all these people are excessively dependent on their visual signals. If you do posturography for these patients, with eyes closed on the foam, like as if Romberg's positive test, they will be veering. Retropulsion is more commonly seen in these patients. Most of the cases of chronic migraine, one may misinterpret the daily or persistent symptoms for those of triple PD. Please don't do this. These patients will respond for serotonin agonists, particularly the triptans. The metabolism of serotonin precursor tryptophan appears to be altered in migraineurs. The metabolism of tryptophan is altered in migraineurs, perhaps it is stored. So that's why the foods that are very rich in tryptophan can trigger migraine. And the neuropeptide Y, it can be a therapeutic target. So before closing this, these are the comorbid conditions that you can have. These patients can have autonomic problems like postural, orthostatic tachycardia syndrome, POTS, or orthostatic hypotension or syncope. They can have migraine. They can have inflammatory disorders like asthma, rhinitis, allergies, thyroid diseases. See, these are all the questions that are need to be asked in the history. You can simply say, what is the relation between allergic rhinitis and migraine? They can be, it can be a comorbid condition associated with migraine. For females, endometriosis, polyps, myomas, and history of hysterectomy. And if you ask females, particularly who underwent hysterectomy, not oophorectomy or total oophohysterectomy, hysterectomy itself. Yes, sir, I have these symptoms 4 or 5 days, something like that. That is actually relating to your menstrual cycle. Only your uterus has been removed, not your ovaries. The hormone regulation is still there. So they can have tissue issues, algias can be there, and skin issues also can be there, even urticaria, psoriasis. And migraines with dizziness have relationship with dysautonomia, hypermobility syndromes, or even mast cell activation syndrome. So that's why few of the patients will even respond for your simple cetirizine. Migraine responding to cetirizine looks like nonsense, right? But I had a patient who came to me and it was not fitting into any of the diagnosis, but also the patient had a history of allergic rhinitis. So then I placed him on desloratadine. Surprisingly, after 3 weeks, the patient came back and said, "Doctor, that drug has given me a miracle." What did it happen? The allergic symptoms are gone. Even my vertigo is gone. Because I never prescribe, or mostly I don't prescribe beta histine. Even though I see like almost 6 patients per day, vertigo patients. Out of 60, 6 will be almost 10% are vertigo patients. Despite of that, not more than 2 boxes of beta histine will be sold out from my pharmacy for entire month. Beta histine independent diagnosis and treatment of vertigo. That should be the agenda. So these are the investigations. You can do a neuroimaging, audio vestibular test, VNG, and EEG. So if you do a functional MRI, these are the things. Vestibular migraine during the next one. So this is the brain of the vestibular migraine patient during the attack. So probably last one, just quickly. I don't want to go to this clinical, no. Differential diagnosis, I don't want to go. For lack of time, just we'll see the findings. This is interesting. So vestibular testing in vestibular migraine. So can any one of you tell who is? The name is here, of course. I want his contribution to vestibular medicine. He is the person who has described the head impulse test. He is from Australia. Professor Halmayagi and Ian Curtois. These two are colleagues, neuro colleagues. So you can classify the vestibular migraine findings into 2 categories, interictal findings and ictal findings. That is, during the attack, you will be having certain findings, and between the attacks, you can have certain findings. I know it is little bit, I'm speaking like too much for the audiology crowd, but bear with me. These are to be learnt at least. So findings during interictal period. The predominant thing or the most consistent thing that you can find in vestibular migraine is unilateral reduced caloric responses. Unfortunately, most of you people who are even performing VNG are not doing calorics. For God's sake, please do this. This is the most consistent laboratory finding that you can find in vestibular migraine. And these patients are 4 times more emetic when compared with the caloric. After doing calorics, these patients are 4 times more emetic when compared to the normal crowd. The higher the emesis it is, more in favor of vestibular migraine, because the patient is not having any symptoms, because it is during the interictal period. So this is how. This is a recent one, 28th November. You can see the asymmetry. Beautiful asymmetry between these two things. And in the interictal period, head impulse is not disturbed. But during ictal phases, head impulse can be disturbed, can be impaired. And the rotatory chair test, if you have a rotatory chair, you can see the reduced gain of VOR can be seen. And in VEMS, reduced amplitudes can be seen unilateral or bilateral. And if you do posturography, most of the times the people will be good. But only the problem is when you ask them to close the eyes and stand on the foam, they will be veering. So excessive visual dependence will be there in these patients during interictal period. And the saccades and the pursuits are saccadic. And whenever pursuit is disturbed, automatically VORS will be disturbed. Vestibulo-ocular reflex suppression test also will be impaired. For VORS to be normal, the pursuit has to be normal, because both of them come from the same area in the brain. That is the flocculus and the paraflocculus. So this is the smooth pursuit in the horizontal plane, very much saccadic. And if you see, with the background, the subjective visual vertical is also tilted to on the same side of the disease. And these are the types of nystagmus what you can see during interictal period. You can see a spontaneous nystagmus, you can see central positional nystagmus, gaze evoked nystagmus, head shaking nystagmus, and vibration induced nystagmus. So this is the gaze evoked nystagmus to the right side. I will be playing both the things parallelly. Gaze evoked nystagmus right and left, different cases. Can you appreciate? Okay. What is this? What do you see? Downbeat nystagmus. Downbeat nystagmus. A downbeat nystagmus is always central until proved otherwise. All the downbeat nystagmus, please get an MRI done. Unless otherwise proved, it is, I don't like to use the word central, but this is the thing. Sir, Harsha, 5 minutes, just you can start having the settings. So this is one important thing as an ENT surgeons and audiologists. During interictal period, the patients can be experiencing sensory neural hearing loss. And the highlight is even few patients can have sudden sensory neural hearing loss. Any patient of sudden sensory neural hearing loss, we have been writing all other medications. We write steroid, we write all the types of vasodilators and all. Please add a medication for migraine. Please add flunarizine for all these patients. Most of the patients, at least 20% will recover. It can be a manifestation of vestibular migraine. And now what happens during the ictal phase? The nystagmus, again you can have a central positional nystagmus, peripheral spontaneous nystagmus, central spontaneous nystagmus. And now here the head impulse is affected. You will be having a defective horizontal vestibulo-ocular reflex. And the saccade will be, the pursuit will be saccadic. If you don't have a video nystagmograph at your clinic, just you can do it clinically. You can see with the pursuit the eye has to move very smoothly. If the patient is like, if the eye is moving something like this, all of you are having a flagship phone. You can record all the eye movements with your phone itself. Or you can make the goggles. You can ask your ophthalmology colleagues, take plus 16 or plus 20 diopters, fix it on a frame and then keep it like this. Always you need not have high-end gadgets, but having them is luxury. Like you can do polyps without debrider and with debrider. With debrider is of course a luxury. Even without debrider, all of a sudden in between, middle of the surgery, your microdebrider stopped working. What will you do? You can't abandon the surgery. You have to go and complete the work. So this is the smooth pursuit, saccadic. And even it can have positional nystagmus, that's why it can mimic BPPV. And see, even it can have a head shake nystagmus during the ictal phase. So this is the head shake nystagmus. See, all these patients are migraine, vestibular migraine patients. And now we have classified this head shake nystagmus in vestibular migraine as 2B and 3A, and this paper has been accepted and this classification has been accepted by the Bharani Society 2024 meeting. Can you see that? Left beat nystagmus after head shake. Now, you see this beauty also. Horizontal nystagmus, direction changing after head shake. Left beating becoming right beating. Intensities are different, but left beating nystagmus becoming the right beating nystagmus. This is the luxury of having a gadget like video nystagmogram. See, classical left beating. After a time, there are few square wave jerks followed by a right beating nystagmus. You can see the time frame here. The right beat, see, now the right beat nystagmus have started. So you should be patient. You should keep the patient at least for 90 seconds after the head shake. This is type 2 nystagmus. This you can see it in uncompensated vestibular neuritis or even in vestibular migraine. In the same thing, the right beating nystagmus becoming the left beating nystagmus. Sometimes even you can see when you do a horizontal head shake, the nystagmus should be in the horizontal plane. But sometimes the nystagmus can be in the vertical plane too. This we will call it as perverted nystagmus. Perversion. Perverted nystagmus. But the problem is all the perverted nystagmus are related to cerebellum or brainstem. But one exception for this is your vestibular migraine. Of course, vestibular migraine is a peripheral as well as central disorder. You can see the nystagmus. Pardon? This one? Sari is getting hurried for the positional things because that is most interesting thing. So we'll conclude here. right? So there are a lot of cases, like you can show many cases for vestibular migraine, and quickly remember this guy, the most happening guy of neurotology now. He is from John Hopkins again, Daniel Gold, neurophysician. See, just you can take quickly snapshots. I can send this PDF to your in the presentation because lack of time I'm moving. Here, what I tried is, you will be having some 6 disorders where vestibular migraine can mimic as. One is BPPV, second is Meniere's disease, third is post-concussion syndrome, triple PD. %38% of the patients will be having oral symptoms like fullness, tinnitus, and subject to hearing loss. And these are actually features of our Meniere's disease. So now coming to the great mimics. So these are the 6 great mimics what you should exclude. Triple PD, BPPV, post-concussion syndrome, Meniere's disease, stroke, and episodic ataxia 2. So what is triple PD? You all know. What I would like to tell is, what are the features that are common in both the things? What are the differentiating things? Vestibular migraine and triple PD, these are the common features. You will be having both may be triggered or exaggerated by a passive motion going on an escalator, or a visual stimuli, bright computer screen or the LED screens like this, or a complex visual cues, watching an action movie, I said you earlier. This can happen in both the things, in triple PD as well as vestibular migraine. Anxiety can coexist in both the things. So for them, sometimes even both of them together can exist, vestibular migraine as well as triple PD. For them, you need to give duloxetine. Duloxetine or venlafaxine can be given. What are the contrasting things between these two? Vestibular migraine is episodic, minutes to days. But whereas symptoms are continuous and ongoing for greater than 3 months in triple PD. The duration of the history is more important. Symptoms are more often than not vary throughout the day, suggestive of triple PD. Completely throughout the day it will be there. Migraine specific associations like headache, migraine triggers like barometric changes, menstruation, or specific foods can trigger the things. It is in vestibular migraine. Coming on to BPPV, you know what is BPPV and all. So the commonest features between BPPV and vestibular migraine. Both may present with episodic positional vertigo. Both may present with ongoing vertigo in certain positions. So usually canal lithiasis, the nystagmus will go off. Okay. But if it is cupulolithiasis, the nystagmus will continue. Or even it can be a case of vestibular migraine. Both may present with geotropic or apogeotropic nystagmus in the ictal phase of vestibular migraine as well as the horizontal canal BPPV. What are the differentiating features? In BPPV, you will be having a crescendo-decrescendo pattern, and in BPPV, it is not associated with any other neurological or atological symptoms. Coming on to the post-concussion syndrome, you will be having a common features like headache, photophobia, phonophobia. But in post-concussion syndrome, as the time progresses, the patient improves. And in post-concussion syndrome, you should avoid topiramate. Avoid topiramate in migraine preventive in patients with cognitive dysfunction due to post-concussion syndrome. Topiramate is contraindicated here. If you are doubtful whether it is vestibular migraine or post-concussion syndrome, please avoid topiramate. And also avoid propranolol as a migraine preventive in patients with significant fatigue due to PCS. And coming on to the Meniere's disease, both the things can be presented as unilateral vestibulopathy, and both the things can be having oral symptoms. But oral symptoms are typically bilateral in vestibular migraine, whereas unilateral in Meniere's disease. But the dilemma arises when there is bilateral Meniere's disease. And if you do an MRI, most of the patients will be having endolymphatic eye drops, even in vestibular migraine. But that will be bilateral. I will show you an MRI. So you see here, this is a normal subject. This is a subject with vestibular migraine where you have enlarged endolymphatic eye drops is there. And in case of Meniere's disease, only unilateral endolymphatic eye drops is there. This is one of the most differentiating feature between the Meniere's and the vestibular migraine. And if you see this asymmetric index here, it is 0%. Both sides equally eye drops is there. But here, there is a huge asymmetric index on both sides. Stroke and TIA is one more mimic. You need to do a HINTS protocol or Stone protocol, whatever it is, like you should exclude stroke. I will send all this stuff on the, and one more important thing is the episodic ataxia type 2. So treatment part also, like we'll be sending you on the WhatsApp so that, sir, BPPV maneuvers can start. No, done. Like some more time, or shall I quickly run the treatment part? Treatment is. I thought Harsha will tell this, but. Quickly run chestanu, yeah. So these are the goals for treatment of vestibular migraine or migraine. To reduce the severity and the duration of attack, to treat the acute attack and also to prevent the attack. Acute treatments, acetaminophen, your paracetamol, simple paracetamol can abort the attack. NSAIDs, ibuprofen like thing. Combination analgesics, ergotamine preparations, and you can give migraine specific preparations, even melatonin and antiemetics. Acetaminophen, you know all the things, and even a normal layman also know about acetaminophen now after COVID. Analgesics, you can give like, NSAIDs you can give the naproxen or even ibuprofen and aspirin. Acetaminophen, aspirin and caffeine, usually we give it for a combination of both migraine and tension type of headaches. When the combination is there, we can use this combination. And I have an experience of using melatonin for 2 patients. But ultimately, again, one of the side effects for melatonin is again dizziness. So coming on to the migraine specific preparations, you have 4 types. One are the triptans, which are serotonin 1B and 1D agonists. You have dietans, serotonin 1F agonist. You have gepants, which are CGRP antagonists. Sounding something like Latin. Triptans, dietans and gepants. Or something like music, jumping Japan. Something like that, but you need to remember this. And I have an experience of almost like 5 years or 6 years for giving Botox injections in chronic migraineurs. And surprisingly, 3 of my entire case series were neurophysicians. They are getting Botox for the chronic migraine. So what are the triptans? Most commonly known triptan is the sumatriptan. You have zolmitriptan, if you have to use it in pediatric cases. You have almotriptan, if you are having a prolonged attack. For menstrual migraine, you can use frovatriptan or naratriptan. Next, coming on to the dietons. Diton is also serotonin 1F agonist. This is the lasmiditon. This specifically acts at the level of the TCC, trigeminal caudal nucleus area. Coming on to the gepants. These are the CGRP antagonists. And for acute managements, you can use abrogepant or rimigepant. Abrogepant is in 50 and 100 doses and rimigepant is 75 in orodispersible form. And intranasal form is also available, zavegepant. And the main advantage of these gepants is they don't cause medicine overuse headaches. So future considerations, where the migraine can be targeted, I have told you, neuropeptide Y can be targeted, and metabotropic and inobotropic glutamic receptors can be targeted. And under research, there is one more thing, glurants. Glurants are coming very shortly into the market. Right now, FDA assessment is going on for glurants. So preventive treatment, till now we have seen acute treatment, preventive treatments. You can give beta blocker, you can give anticonvulsants, tricyclic antidepressants, calcium channel modulators, or monoclonal antibodies for the CGRP. CGRP monoclonal antibodies like galcanezumab, fremanezumab and eptinezumab or eridumab. These monoclonal antibodies for CGRP are recommended as the first line therapy for chronic migraine by European Headache Association. The consensus in 2023, I think, 2023. Yeah, I have written here. So, other treatment modalities are neuromodulation, transcranial magnetic stimulation, mostly done for the psychiatric cases, depression, that also can be given for the as a preventive treatment for migraine. Next, most important thing is the lifestyle modification. Whatever medication you give, unless you modify the lifestyle, these symptoms are not going to subside. Like I say in this way, తిండి నిద్ర ఈ రెండు సరిగ్గా లేకపోతే మైగ్రేన్ వస్తూనే ఉంటుంది. You do whatever things, you take whatever things. So good sleep, good food. And some other drugs like riboflavin, magnesium, coenzyme Q10 can also be given. So other general managements you can use for nausea, ondansetron and prochlorperazine. Aerobic exercises can also prevent migraine. So coming on to the preventive things, I have already told these things. Flunarizine, botulinum toxin, anticonvulsants, antidepressants and beta blockers. This is the most common preventive method. You have to follow a technique called as elimination diet. You have to exclude most of the things from your diet for a migraine patient. Migraine means vestibular migraine. Vestibular migraine means migraine. You have to give a diet with low fat content, high folate content and ketogenic diet and a low sodium diet. So these are the recommended migraine diets. Things that are to be avoided, things that are accepted. Coffee, chocolates, alcohol, dairy products, you need to avoid. At least remember what not to give, so that except that, baki all things you can give. In meats also, canned meat is not allowed actually. And more monosodium glutamate foods, soya sauce, most of you are like the favorites of Chinese foods. All the Chinese foods will be having this MSG. So no artificial sweetness. Vegetables like beans, Italian beans, even onion and olive also has to be excluded from their diet. In fruits, try to avoid avocados, papaya, and particularly like bananas and over-ripened fruit. Any fruit, any over-ripened fruit, they should not take. So hope you have taken this thing, but anyhow I will be sending you on WhatsApp because the diet and all are very important apart from the medication. So sorry for rushing through the things because of the time constraint. Actually it was supposed to be 4-hour session, vestibular migraine. So next comes the BPPV, diagnostic maneuvers and therapeutic maneuvers. A quick demonstration by Srinivas sir, followed by the hands-on.
Maneuver is this one. What we do is a head positions test. Okay. So I will do all that I do in the clinic for you, so that can you all see me if you are together? It's okay? Fine. So in the head positions test, what we do, okay, all this is there on the YouTube channel. Okay, for revision you can always go back to the YouTube channel and listen. So what you do, the first step is just turn the head to the right side. Okay. This one test, there are two tests which can be done only with a VNG goggle. One is the head positions test, another is the bow and lean test. They are designed for a goggle. Previous to that, so many tests were there that was designed for examining without a VNG goggle. Okay. So for this one, you need a goggle. So what happens here? Okay, is it coming? Yeah. You can see double, you can see me also. You can see there also. Head 0 bertara. Is the eye video good? Okay. Head 0. Head 0. Okay, fine. So the first step here, of course, this is done with the visor closed. But what we do is, the first step is your right. This one. Okay. This is your right. Can you see that? No, that's okay. Straight unda. Adem parledu. Work chustunte chalu. No, head 0 betara. Yes. Okay. Can you see the character there also turns the head right? Okay. So this is your right. The first step is your right. In your right, you will get an nystagmus, sustained nystagmus in some people with migraine. Okay, sustained nystagmus. But you will also get a patient who may not show that much of a nystagmus. So in this test, you always ask the patient to keep talking to you something like British Constitution, something like that, or something in Telugu, something like that. Something you can tell the patient so that they can keep repeating it, because you want to know the moment the person's speech becomes slurry and you will immediately stop. Okay, because this will rule out any rotational vertebral artery syndrome. Rotational vertebral artery syndrome is one of the vertebral arteries is stenosed. So when you turn to one side, the person will start developing this thing. So you keep telling British Constitution like this, and then nothing happens for 30 seconds, then lift the head up. Then again keep telling British Constitution like this. Okay, no slurring, perfect. Then you go to the other side. Then again maintain for 30 seconds, continue to say the same thing, and then look up. Okay, that also 30 seconds you maintain. So this is like a test for migraine. This is also a test for rotational vertebral artery. Some patients with hypersensitive carotid sinus, they also develop fainting or syncopal like tendency on turning the head to right or left. So many conditions are taken care and evaluated and screened for in just 2 minutes. Next thing is pitch forward. Can you see that? This is a pitch forward. Okay. This one is a very good test. One is in postcanal BPPV, sometimes you will get a downbeat nystagmus here. But more common than that, sustained downbeat suggests that there is a cerebellar dysfunction. That can happen even in migraine people, and that can happen in neurodegenerative conditions also. That is of the cerebellum. Then you go up like this. This is the lean. So this is a bow test. This is the pitch forward, and this is the pitch backward. Here if you see horizontal nystagmus, then the person has lateral canal BPPV. If you get downbeat nystagmus, it can be seen. If it is downbeat nystagmus shows with a torsional component, it is posterior canal. But if you get a downbeat nystagmus, pure vertical downbeat, then it is cerebellar. Okay, it's a cerebellar dysfunction. The moment I say cerebellar, it's not like you should get a tumor or anything. As simple as a migrainous cerebellar dysfunction, as simple a condition as a thiamine related cerebellar dysfunction can present like this. So that is what we should keep in mind. Then when you go up like this is equivalent to lean test of this thing. Here if you get horizontal, that is lateral canal BPPV. Is that fine? Okay. Next step after this is lying down on the right side. Okay. With a pillow you lie down on the right side. Then this is again equivalent to, in the macular pectinii, that is the supine roll test, rolling to the right. So if I get a right beating nystagmus here, then if I get a left beating nystagmus here, what is it called? Geotropic. Is that fine? So it is called as a geotropic BPPV. So far clear everybody? Everything is clear? Fine. So this is the head positions test. I want you to notice something. Can you see when I am moving my head, can you see there is a nystagmus there? Could you see that? See, when you see this, when I go like this, somebody hold this so that I don't topple off. Can you see the nystagmus? Can you see the nystagmus? Can you see the nystagmus? Vertical torsional nystagmus? Do I have BPPV? See this. Can you see that? Can you? Hi, come, I'll make you see. Come. Okay. Okay. So that is vertical torsional nystagmus. This is per positional nystagmus. That is why it is so much of a fallacious thing just to look at the graph without simultaneous access to head movement data. Without simultaneous access to head movement data, if you do this, then you are going to get a wrong diagnosis. You will think that if somebody sends you only video, only graph or only video without access to the head movement, then you will simply make a diagnosis, wrong diagnosis of posterior canal BPPV, anterior canal BPPV. That should not happen. Okay, so always, that is why only two things. Either the person who is doing, he only should give the diagnosis. Otherwise, whoever somebody else is helping you should also have access to what was happening to head movement at that particular point of time. Only a nystagmus that happens after stoppage of head movement is pathological. When the head movement is ongoing, at that time if you see a nystagmus, this is per positioning nystagmus. Per positioning nystagmus can be of multiple varieties and that itself has pathological significance. That is separate. So I will just demonstrate what are all the per positioning nystagmus that is possible. Recording start Ji. Just work start నొక్కు చాలు. ఒక్క నిమిషం. ఓకే, 1 minute. ఓకే, yeah, okay, fine. Just see. Okay, start. Can you see the right beating nystagmus? So this is per positioning. When I am turning to the right, right beating nystagmus. When I am turning to the left, left beating nystagmus. When I turn right, right beating nystagmus. Stop that. So this is to demonstrate in the old version software. I know. We'll just take the latest update, okay? Okay. No, you should have taken the latest. Otherwise, do you have the MSI charger? So that I can, otherwise leave it now, okay? But then in the actual the version of the software, we have a third graph which will tell the head was moving at that particular point of time, okay? I'll post it on a YouTube so that you'll see. Now we don't really, I forgot my charger in Haryana. I was there in Haryana AOICon yesterday. My laptop's charger I forgot there. So because of that I didn't carry. That is okay, no problem. Okay, otherwise I wanted to show that. But then I want to show all the varieties. Huh? That is okay, sir. March time bartagada. Okay. Okay, fine. That is okay, fine. I'll put it on YouTube, okay? So that for you also there is a motivation to see my channel, okay? Fine, fine, okay? So now one more thing I will show you, okay? So what are all the different things that are possible in per positioning, okay? What is this? I have turned to one side, correct? Yeah. Start JND. Next test bit start JND. Start Jesera? Started? Beating nystagmus. Left beating nystagmus. I stopped. Right beating nystagmus. Left beating nystagmus. Done? Stop it. This is called the mountain plot. Can you see down? There is a mountain plot on the bottom. Can you see here, all of you? There's a mountain plot. This mountain plot is when the head was moving. That is when you got the nystagmus. Okay, there is no head movement here, no nystagmus here. Okay, this sawtooth means nystagmus. There is no nystagmus here. If you see the mountain plot, there is no head movement there. Is that okay? Sorry for this in the center, that's okay. Okay, but you can make out. There are a lot of things that are there, okay. All of you could see the mountain plot? Okay, search and do. So that is one thing. I'll show something more here. Then I'll go back to this thing. But what I wanted to tell you is any position, any nystagmus can be produced during the head position change. So I will demonstrate all those things. Start. Started? What nystagmus you are getting? Hey, what happened? That was the head positions test. The next test is the Maclear-Pegnini test. The first step of the Maclear-Pegnini test, this is ideally suited for lateral canal BPPV. The first step of the Maclear-Pegnini test is going from the sit position to the supine position with a pillow. Is that okay? With a pillow. Then you turn to the right side, 30 seconds. Then you come back to supine. Then you turn to the left and 30 seconds. Then you come back to supine position. Is that okay? Fine. Interpretations. Full body turn. Full body turn. Okay. Full body. You turn the full body. You turn the full body. Okay. Everything is there in the channel. Positions test is there. Any doubt is there, you just go back, see how I have done, just do the same thing. Is that fine? Okay. Any doubt is there? It's interpretations. On right side, right beating. On left side, left beating is called as geotropic. On right side, left beating. On left side, right beating is called as apogeotropic pattern.
Any lateral canal should have any geotropic, apogeotropic pattern, or only single, like right horizontal, only right beating.
If the debris is very minimal, then you will get excitated nystagmus on only one lateral position.
Other no nystagmus.
No nystagmus on the other lateral position. Then if on right side you get right beating nystagmus, then it is right sided BPPV. That is where I talked about the 6 nystagmus and 3 rectangles principle. If you get only one nystagmus, just directly apply the chart. Clear, sir? That's all. So
No need for any geotropic or apogeotropic.
geotropic is only if you get on right side right beating and left side left beating. If you get only right beating on right side, nothing on the left side, you don't call it as geotropic. You simply say that it is. It can also happen. It can also happen. The geotropic apogeotropic is much more common in lateral canal than only a single nystagmus on one side. Much more common. Okay. So that is. But theoretically, it is possible when the debris is very minimal. Is that fine? Take your time. Aram se. Take your time. Huh? 4477. That is my ATM password also. Okay. I am so confident because not much is there in the account. Okay. Fine. So that is now interpretation number 1. You know here whichever nystagmus beats. Yeah. You can move the only head instead of the whole body. The only problem with moving only the head is you are introducing another confounding factor, cervical proprioceptive input, and also vascular any vascular etiology to that. So I don't want, when I'm studying, I want to keep it simple, very simple. I want simple man. I evaluate one at a time, not multiple at a time. So if the person gets a nystagmus, if I roll the entire body, I know that nystagmus has to be only because of BPPV. I don't want cervical proprioceptive contribution. I don't want vascular compromise contribution. None of those things I want. That is the only reason why I want to roll the entire body. Is that clear? Okay, that's it. So interpretation number 1, you got it. Interpretation number 2, cupular pathology or canal pathology. Canal problem or cupular problem. When you first go to the supine position, it is called supine 1. When you go to the right and then come back to supine, it is called supine 2. When you go to left and come back to supine, it is called supine 3. In case of cupular pathology, supine 1, supine 2 and supine 3, the nystagmus will be same direction. If it is right beating, it will be right beating here, it will be right beating here, it will from here, from that side also it will be right beating. Cupular orientation with respect to gravity does not change. When you are in supine, it is always that same orientation. Is that okay? That is cupular pathology. That is number 1. There also there are so many things that you can make out. Okay, without complicating things or whatever. Like for example, if this is left beating, on right, if it is again left beating, on left it becomes right beating. So left beating here, okay, on left beating, okay. So it is like you can make out how things are changing. So on supine, left beating, right lateral left beating, left lateral right beating. What is it? This is apogeotropic pattern. Supine is left beating first also, supine second time you come also it is left beating, third time you come also it is left beating. Supine is left beating, on the right lateral it is left beating, on left lateral it is right beating. Which side is the affected side? Which side is the affected? Multiple clues are there. It is geotropic or apogeotropic? It is apogeotropic. In apogeotropic, the nystagmus beats to which direction in the supine position? That side is affected side. Okay. Easy to remember. Where is Pradeep sir? Panchabhut sign he calls it. Okay. So because you are looking, apogeotropic means sky nystagmus, correct? Okay. Apogeotropic is sky nystagmus. Is that correct? Yes. So when you lie down like this, what are you looking at? So when you are looking at the sky, which side it beats? That side is the affected side. Is that okay? Then in the head positions test, I told about pitch forward and lean backward. That is bow. Bow, when you bow, you look at what? Earth. So whichever side it beats in that, if it turns out to be geotropic, if it turns out, there's a lot of confusion, people will tell. Why you got confused is, at bow and lean only you want to tell which side is affected. Don't do that, don't do that, don't do that, don't do that, don't do that. Write down here. Again you will be same confused. How many ever times I tell, this is the same confusion, because again, in spite of telling also, you will start thinking, sir, which side is the affected side in bow and lean? No, you don't tell which side is affected during bow and lean stage. Bow and lean stage is data collection stage, not interpretation stage. In bow it was right beating, in lean it was left beating. Fine, write it and keep that. Later on, when you do the right roll and left roll, if it was geotropic, then refer to bow position. Geotropic is ground beating. So look down. Looking down, because this is ground beating, while looking down, which side it was beating? That is the, this thing. That side is the affected side. When looking up which side it was beating, you look for when it comes to apogeotropic. That's all. So, Mother God of Earth will tell, okay, Earth God will tell, Goddess Earth will tell, Prithvi Mata, when geotropic. And Akasha, Lord of the Akashas, will tell when it is apogeotropic. This was made very easy by Pradeep. He is very good in making things simple for everybody. He tells Panchabhut sign. That's it. Over. Done, sir. His Panchabhutala Sakshiga time is still not come. He is still a bachelor. Huh? He is still a bachelor, eligible bachelor. I'm just announcing. Okay. Okay. Fine, fine. Fine. So next thing is, so that was interpretation. You saw the, you know the interpretation of right, left, everything. Okay. Fine. Next thing is a Dix-Alpine test. Is that fine? Okay. I'll do with the this thing. After that, I'll go to this one. Okay. In Dix-Alpine test, what you do? You turn the head 45 degrees to one side. My way of doing it, okay, I'm doing it, the term for that was given again by Dr. Pradeep. It is called augmented Dix-Alpine test. You first step, you make the person look down. Why this is important is, posterior canal has a horizontal part. The debris can be anywhere in the horizontal part. When you do this, it all goes forward. Now you go down 45 degrees like this, and then you go like this, and sir, leave. It has to go down. Okay? More than 45 degrees. Up to 45 degrees, you go down. Okay, like this. Wait for 60 seconds, even if there is no nystagmus. Very common mistake. Patak. No nystagmus. Yeah. The debris needs time to move. In some people, it comes after the 50th second. I have seen that. So you have to wait. Don't declare a person does not have BPPV just by doing for 10 seconds, 20 seconds, you don't get. You have to wait for 60 seconds. If the history looks like BPPV and you don't get it positive first time, repeat it 3 times before telling this person is negative. This is 3 times my recommendation. I'll tell you something. Where is Harsha? Harsha is behind me. He had a patient, he got it on the 8th time. 8th time, kada? He knew it is BPPV. It is not coming. It is not coming. It is not. The 8th time it got mobilized. The debris got mobilized. Okay. So like that. So that is this thing. That is extreme. But how much clinicians' courage of conviction is important to know this is BPPV only. It is not coming. I will do. I will do. That needs this thing. This needs applause. Correct? 8th time. Huh? Huh? Patient will cooperate as long as the clinician has that composure, confidence. Clinician should be like, I know your condition. I have seen this multiple times. That debris will not move that time. It is moving in his home. Okay, it is moving in his home. It is coming. So sometimes it doesn't come. It challenges.
The thing is like,
Second time we do it doesn't come.
Yeah.
the thing is like in the canal when the particles are moving, it should be of a sufficient mass. All the particles should clump together, and that makes the endolymph to be moved. Few particles moving with each maneuver. Probably after all the maneuver, 3 or 4 times, all the particles will clump together so that it gains like a piston.
Yeah.
Moves the endolymph part. That would be the reason.
So try multiple times if the history is very, very suggestive. Okay, that is the most important. So what is the message here? Dixalpike test, 60 seconds minimum wait and this thing. Then what is the common mistake? Why don't people don't get in Dixalpike test? Again, it is positive, but the technique is a problem. Why you don't get? I will tell you why. The entire idea of Dixalpike test is the posterior canal is oriented like this, and when you go down, this becomes vertical like this. Okay. But if you do like this, it is still 45 degrees slant. Is that correct? It is slant like. So it is like a horizontal. If you do 45 degrees like this, then it becomes like this, vertical. It was like this. Now when I go down, this becomes vertical. Is that clear? Now if I do more than 45 like this, then again it becomes a slant. It is as good as doing straight. You rather do straight now. Got the point? So don't overdo. Every time why I insist on checking everybody's Dixalpike test in any hands-on workshop is, this is the commonest mistake I see, where they overdo this. Second thing is they don't extend enough. These 2 things. So extend enough and don't overdo. Extend enough does not mean that you actually pluck the head out and, okay. Within the comforts of the patient, you do the extension, then you give. Is that okay? That is the Dixalpike diagnostic. These 2 tests, McClure-Pagnini, Dixalpike head positions test will take care of a lot of things. But there is one more test. You have come so far spending a Sunday, so completion should happen. Other test is called straight head hanging or deep head hanging test. Okay, supine straight head extension. I don't like that word hanging and all those things. So I called it a supine straight head extension test. Okay. How many like the word hanging? Okay. So supine straight head extension test. So what we do here, straight, you go back, and then turn the head like this, okay, on the back, 90 degrees like this, okay, more than 70 degrees, and then look for any nystagmus. Again, wait for 60 seconds. Is that okay? If you get downbeating nystagmus, that is anterior canal BPPV. Okay, that is anterior canal BPPV. Is that okay? Same, what did we see? Torsional nystagmus. It is written in the books that anterior will not have torsional, nothing like that. Anterior also show torsional. It shows torsional. Okay. So torsional beats to the right means downbeat torsional right which canal? Right anterior. Downbeat torsional left? Left anterior canal. That's all. Okay.
Anterior canal, when you do a therapeutic maneuver, it does not matter whether it is right or left.
A therapeutic maneuver does not matter. Yeah. 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 Fine. Okay. So you ask the person in the sitting position, how much can you do this and show. Within those limits you do. Otherwise you take him to the minor OT table, put it in the reverse Trendelenburg position and put it. Because testing and repositioning is dependent on head position in space, not body to head relation. You should just get that head orientation in space. That's all. So whether you get it with a reverse foot and up tilt or you get it just like that, it doesn't make a difference. There are some times where I put a cot on this. There was one in Mumbai, I was giving a demo. There was one patient, it was not getting corrected. We put the cot on the stage like this, two legs of the cot on the stage, other two legs of the cot down. And then we did the maneuver. The neck was bad. Okay, it's like that. So you can do, it is a neck in space. Ultimately, it is exactly like surgery. One instrument is not working, you take the next instrument and finish it off. Is that correct? That is it. It is not like this only has to work or anything like that. Sir also was telling.
Like I am using a derma chair.
Huh.
I'm using a derma chair for doing these maneuvers. Actually, that is much better than our regular couch. But of course, to you, I do both these three procedures as well as this thing. So I'll be utilizing for both the purposes.
Okay. He has a good aesthetic surgical setup also. He does Botox, he does everything. Okay. So he also start Botox, all this. Okay. So patient comes for nothing will happen. No. Very rare. Very rare. I have done so. Then orthostatic hypotension has to be treated. Of orthostatic hypotension, if the diagnosis is orthostatic hypotension, the orthostatic has to be treated. Okay. No, see, that is very, very rare. Okay, like I have also been practicing for so many years. Please don't give me this complicated cases. Okay. Okay, please. Orthostatic plus this. It is there, but then they also come seeking if the doctor is really competent, then all these cases will come. For simple doctor, simple diagnosis will come. Okay, we will get simple cases. But if the orthostatic is there, that has to be given attention. Okay, that also has to be given attention. Vasovagal, yes sir, Chapan sir. See, there is a reason about all those things, then I can get into that why cervicogenic came, why cervicogenic went, why cervicogenic is peeping back in, all of those things are there. So that again can be one more day. Okay, so next Hyderabad meet will be neck and vertigo. Okay, okay, fine. Is that fine? Okay, fine. So now the next thing is, because that will take half an hour discussion, that's why I am just avoiding. Okay. So now, okay. So, but basically because you mentioned it, what are the reasons when the neck can be involved in vertigo? First and foremost, the person has BPPV. Okay, if somebody has BPPV, the person has BPPV, because of secondary to BPPV, will start holding the neck tight. The loss of cervical lordosis is done. If you do an X-ray, loss of cervical lordosis is written. Is that fine? And then they'll tell that person has vertigo because of cervical this thing. And they'll put on a collar. And he'll tell, lie down slow, lie down, get up slow, and all those things. BPPVs go on and on and on. We have seen people for years together, BPPV not treated just because of this nonsense. One X-ray and then there is something that. So number 1 point. That is first. Second one is, lot of people with migraine and Meniere's and migraine-Meniere overlap syndrome, they will always tell their vertigo starts with a neck pain. So that is migraine and neck pain. Neck pain is part of the vertigo. Third one is people with rotational vertebral artery syndrome. They also can have on turning, but that is a rarer diagnosis. They can also have the neck. So basically when you see, most of the conditions, 95% of the conditions or more of so-called cervicogenic those days used to be BPPVs which are not tested properly, inadequately treated. So it became a responsibility for all of us those days who were teaching this thing, continue to teach now also. If you go to Pune, Dr. Sudhir Kotari, anybody, the first thing they will tell is cervicogenic vertigo does not exist. Why? Because they are seeing the pain of seeing the morbidity of untreated BPPV, and there has to be a strong message that is sent to the community that this, please don't accept cervicogenic vertigo just like that. Is that okay? Having said all these things, that is the thing. Finally, whether the neck can contribute to imbalance, then if you take to that level, then in the cerebellar, deep cerebellar nuclei, we know that cervical proprioceptive inputs and vestibular inputs interact. Okay, interact. Therefore, there is a possibility that a real problem in the cervical, deep neck pains, okay, deep neck muscle spasms can present as wavering or swaying while walking. We have seen patients with deep neck spasms, which patient have had a fall, all these things. The moment that spasm is relieved, the patient's walk becomes normal. Now in this stage, if you reach that advanced stage of practicing, then my effort has been, I talk to both physiotherapists, ENTs and neurologists, everybody, to convince the physiotherapist that there is migraine which is causing a lot of your patient's neck problem, not any muscle problem. To convince the neurologist and ENT that there is a neck spasm that can also cause balance issues. Both of them keep your mind open. But if you still give me 5 minutes, I will tell cervicogenic vertigo does not exist, because we need to send home that point that you should not accept just like that. See, if Dr. Pradeep makes a diagnosis of cervicogenic vertigo, then I will accept it, because he has ruled out BPPV, he has ruled out everything, and then. But if somebody just has done one cervical X-ray and then tells I have been diagnosed with cervical, I will first throw away that X-ray. It is like that. So this is the context. So there are two levels of understanding. There is a top level of understanding the Bhagavad Gita, and there is the deep understanding of the Bhagavad Gita. That's all. Is that fine? So that's it. Yes, sir. Yes, sir.
I have a patient.
That is very, very important to this thing. I have seen a patient 40 years. She was 70. She started getting problem at 30. 30 to 70, she is suffering. Everybody in her family was telling she is mad. Acting, doesn't want to work, everything. Her entire life is spoiled. Mother-in-law never understood that this is this thing. She became a mother-in-law. Still, daughter-in-law did not understand. This much problem. You know what she did? Last 70 years when she told, how many ever rest of my life, I don't know how much is left, but every day I go back home, I will light the lamp in your name, she told, and she went. Okay, this is the morbidity of BPPV. So when you make a egalitarian diagnosis after having considered everything, I will accept. But somebody comes with an X-ray and tells that I am cervicogenic vertigo, then I will tell, please. So all our thing has been this thing. So physiotherapists, we tell migraine, please consider migraine in your stiff neck patients. The other people, we tell, if they are not responding to migraine, please consider the possibility that there is a tight band somewhere deep inside. Okay, like that. I work with one physiotherapist who does dry needling for this tight bands. Okay, so like that. So it's a 360-degree view. Fine. So your half an hour you have taken. Okay. Okay, fine. So the next thing is special extra charge from. Okay, fine. So the next one, the Dixalpike, some more modifications of the Dixalpike. When you do this and when you go down like this is for the canalolithiasis variety. But this does not show up everything. This is the cupulolithiasis. For cupulolithiasis, you have to put the head 30 degrees up. This is called half Dixalpike test. Half Dixalpike test. Again, this is there in the videos on the YouTube channel. Okay. I will see how many people are watching, because I get the view counts and all that. Okay, fine. So that is the half Dixalpike is that one. Now next thing is about short arm. In short arm, what will happen? There are two clues to short arm. Do you remember the two clues to short arm posterior canal? What are the two clues? One is, this may not be that symptomatic, but this getting up is very symptomatic. Sitting up vertigo. And during that time, okay, most of the nystagmus is per positional. Very rarely also you get after getting up also upbeat torsional. Generally, you get upbeat torsional in which position? In Dixalpike. But if you get upbeat torsional of a significant intensity on sitting up, that is one place where you suspect. Second thing, in fact, that is the more common type where you should suspect is your posterior canal BPPV not responding to maneuver. Is that okay? Your posterior canal BPPV not responding to the routine Epley maneuver is the person who has a short arm. So clear? That is done. This is BPPV PhD level discussion that you are now going through. Yeah. So cupulolithiasis can be both sides, canal side and the utricular side. It can be there. It can be there. So I have seen those patients. I will tell you, most common horizontal canal. and the horizontal canal. So I'll come to the horizontal canal therapeutic maneuvers. Okay. Now shall we go to the therapeutic maneuvers? So what is therapeutic maneuver? Do you all remember the diagram of the horizontal canal I review? The last one was coming straight up like this. Correct? You remember? If it is coming straight up towards the nose, if from there the debris has to fall, the nose has to be down. But when the nose has to be down, when the debris reaches there. Morning what we saw, we did a discussion called therapeutic direction flow and therapeutic direction nystagmus. Is that correct? So now, what is therapeutic direction flow and therapeutic direction nystagmus? It has to go in this direction, right side. It has to come from front like this and then it go. Correct? The nystagmus it produces is left beating. Eye goes like this and it is left beating. Is that correct? Now let us say, for sir's question is, where is the debris? Is it on the canal side or on the cupular side in case of cupulolithiasis? So the last position of treatment is nose down. We have three very common therapeutic maneuvers for lateral canal. One is called Zuma maneuver. Another is called Lempert's barbecue roll maneuver. Another is called Guffoni maneuver. All the three positions tests, last position is nose down. In Lempert's barbecue roll, you roll and the head comes nose down. Oh, is that fine? I will show that. I will just show this concept first. So in the Lempert barbecue roll, this is for canalolithiasis. I will come to sir's question later. Like this, you turn 90 to one side, 90 degrees to one side to clump the debris together. Then you start coming like this. Now the debris starts moving. Now you will start getting left beating nystagmus. Is that correct? Now you go like this. The left beating nystagmus will continue, telling that the debris has come. Is that fine? In McClure Pegnini, you come back, then it will become right beating nystagmus. But in therapeutic maneuver, you go down like this and you go prone. Is that fine? And here the person gets up on all fours. Is that okay? This is Lempert's barbecue roll. The nose down is achieved like that. Is that clear? Then there is Zuma maneuver. Zuma maneuver is for apogeotropic. In apogeotropic, what you do, you want the debris to fall from the cupula. And the cupula becomes horizontal when the nose is fully down. So what I start off? I start off like this. Is that okay? So I fall to this side with the legs down. I fall to this side with the nose down. Is that okay? Then I come like this. This will start the therapeutic direction flow if it has become loose. Is that okay? Then I go like this. The flow continues. Now it is like a canalolithiasis. Is that correct? Which beating nystagmus? Left beating nystagmus. And then you continue like this. It goes like this. Now in Zuma maneuver, the nose down is not achieved by going down. You make the chin touch the ground, chin touch the chest, and then person sits up. Clear? Hello? So this is how it is done. Same. It is achieved differently. Can you mix and match? You can mix and match. It is as good as a boutique. You can do whatever you want. Is that fine? You can mix and match. If the person, you want to do Zuma, but the person cannot bend, you go from prone. You want to go prone, but the person has knee problems. You wanted to do Lempert barbecue, not possible. You end like a Zuma. All of these things like surgery only. Is that right? It is just like surgery. You should know the principles. If you know the principle, the final position has to be nose down. How you achieve it is basic. Last, Guffoni. Guffoni is another one where the same thing is achieved. In Guffoni, what you do, if you have to treat the right side, you have to fall to the left side like this, and then the nose is turned down like this to cause the debris to flow in the other direction, and then the person turns up. Is that okay? Now we need to have the concept of therapeutic direction roll. You would have noticed right side I was treating, always I was rolling to the left side. Is that correct? Including Guffoni maneuver. The roll is to the left. the therapeutic direction roll is always to the opposite side. Is that fine? The only difference is the starting position. In cupulolithiasis, you have to move from here. So you start from right lateral and then go to the other side. In canalolithiasis, you start from supine, little bit mobilization, and then you go to the other side. That is the only difference. Clear, everybody? So concept wise, we know it is not like just we are mugging up how to do. It is a concept where you are starting from. With this concept, again, you watch the videos, you will know. Is that fine? So Appiani. For Appiani, you fall to the affected ear. A for Appiani, A for affected ear. So what do? You fall to this side so that this particular part, see, horizontal canal goes like this. It goes front and then it comes up. So you do like this, then only it becomes horizontal, this part. The canal comes like this, cupula becomes horizontal. That is why this 45-degree tilt is important in Appiani. So you fall to this side, nose down. Then look up. Okay? Up towards the sky. That is the Appiani maneuver. Here also, see the thing. Right side is affected. You fall like this. Which side am I turning? Left side. You got it? Ultimately, the roll. So, therapeutic direction roll is always towards the left. Only the beginning position changes. Therapeutic direction nystagmus always beats to the other side. Now, I will come to Sir's question. What is Sir's question? What if if it is apogeotropic, what if it was on the other side of the cupula? Is that correct? So, this is where this is very important. When you start off the Zumba maneuver for apogeotropic, you start off by falling like this. Is that okay? This will produce apogeotropic right side. Which beating nystagmus? Left beating. You come here, it will continue to be left beating. If it has released from the cupula, if you come here, it has become a canalolithiasis, it will continue to be left beating. Correct? Hello?
Yes, yes, yes.
But if it has not released from the cupula, in this position, supine position, remember, in the supine position, when you are looking at the sky, apogeotropic beats to which side? Affected side. Which beating it will become? If it has become right beating, has it left the cupula? It has not left the cupula. So if you try one more time also, then also it is not left the cupula. Again you come here, it is changing. This is where this is very important. Therapeutic direction nystagmus. The therapeutic direction nystagmus is not continuing. If you are doing it correctly, the left beating should have continued till you end. It is not continuing till the end. The left beating nystagmus suddenly started becoming right beating. That means it has not left the cupula. Now if you simply not knowing, if you turn the other patient to the other side, patient will become ampulopetal deflection, intensely nauseating, they will vomit, they will have all these things in the clinic, we'll have a scene in the clinic. That moment only you come to know, no, it has not relieved. No, why should I turn to the other side? It has not left the cupula. Then you will not do. Then what you know? Fine. So it has not left. Perfect. So what? It has not left. 2 times you try, again it has not left. Then what is the conclusion? Probably it was not on this side, that is why it is not leaving. Maybe it is on the other side. But same thing, when do you suspect short arm? When routine Ipli is not working. Just like that, routine Zuma is not working, maybe it's on the other side. Then what you do? Do the other canal. Which side was? The right side. It was there. Turn the head like this. It becomes horizontal, like this. Now, you fall to this side very fast. It will just drop off. Single step maneuver. Is that okay? That's a single step maneuver. You just fall like this. Done. It will be taken care. Okay, look to the right and fall to the left, it will be taken care. This is what it is. We should get a surgeon's approach towards vertigo. As long as you don't look at vertigo like a surgeon with a surgical mindset, this is surgical mindset. Okay, this is, without a surgical mindset, this becomes too complicated. You have a surgical mindset, you know, it is not on where, it's on the other side. That's it, over, matter close. Clear? That is how vertigo has to be approached. This is lateral canal. So you remember all the maneuvers? I'll just demo because this was during a discussion. So Guffoni maneuver, it is done for which? Geotropic. You remember GG. Right side, to treat right side, turn like this, good ear, towards the good ear. You fall towards the good ear very fast. Then head goes down and then you get up. Clear? That's all. Appiani converts geotropic to apogeotropic. How you do that? You do this I mean, you do this, you fall to this side, and then you go up. That's all. That converts apogeotropic to geotropic. Afterwards, you have to do a Guffoni. After that, you have to do a Guffoni. Is that okay? Clear so far? Zumba maneuver. I lie down on one side, like this. Then I come like this. Then I go like this. Then my chin turns, and then I sit up. Is that okay? That is Zumba maneuver. Clear to everybody? Yes. You have to. That is the modification. That is my modification. You turn the head and then you lie down. Okay? Okay. Zumba. Is that okay? So you know all the maneuvers now. Lempert's barbecue roll. Lie down like this for the right side. Turn 90 degrees to the side. This is non-therapeutic direction, but we are doing this to collect the debris together. And then you come like this, you go like this, then you go prone and then get up. Okay, full prone. I am not doing it here. You can see in the videos. Is that fine? So that was about lateral canal. Lateral canal mastered and it is safe in your pockets. Is that correct? Clear? So now what you do? Posterior canal. Okay, so posterior canal. So, sir?
Only for geographic, sir.
So you start to the like this, fall on the good ear side, and then move the nose towards the ground. G, G, G. Apogeotropic. For apogeotropic, you fall towards the affected side with the nose down like this, then look upwards. Then look towards the ground, then look towards the sky. Remember that, okay? And all these looks like memory. If don't memorize this, don't memorize this. Start looking at the anatomy. Okay, the horizontal canal goes front like this and it comes like this. The orientation of the horizontal canal cupola is like this, like an A. When you turn like this, it becomes horizontal. It's a A orientation. Right side's cupola is like this, like this. Just remember this much. Now you tell me what you are supposed to do if you are to mobilize the debris from here. Turn like this and fall. Is that okay? And then once it has become loose, you turn up so that it starts going down. That's all. Okay, remember anatomically. Okay, fine. Is that fine? Otherwise, how much do you want to remember new things, one more thing? Afterwards, it becomes a habit. That's a different issue. But in the beginning, just go by awareness of this one. So do this and then fall. Is that clear? Okay. Is for geotropic. See why? How the difference? What is why barbecue is for geotropic? Why Zuma is not for apogeotropic? Where do you start from? In barbecue roll, where are you starting from? You are starting from this position. You are not able to mobilize from the front part. Okay, the front part comes like this and it comes like this. I said no, horizontal canal. When you go like this is the basic barbecue roll. I may do little bit. Very luckily it may come down, but it is not designed for that. If you do a Zumba, you turn like this and you fall to this side. Now the frontmost part will become mobilized and it will go down. From now you start turning. You got it? Understood? So what did I tell? Therapeutic direction roll for the right side lateral canal is always towards the left. Last step of lateral canal is always nose down, wherever you get it. The only difference between apogeotropic, geotropic, starting position. What is different? Starting position. The only thing is starting position. For geotropic versus apo. Clear, sir? Starting position. For geotropic, for apogeotropic, you start from a more extreme position so that you have to bring out from the front. That's all. Okay? That's all. All these things, go home, start writing diagrams, it will become super simple. Is that fine? So only difference is starting position. So we have laid down the principles. Is that fine? Now coming to posterior canal. Posterior canal, we have two maneuvers. One is the Simont maneuver, another is this thing. So this is not this thing. The way I do Simont is, I take the hand up, I go to the edge, and then I go down so that the head is looking upwards. Is that okay? And then I go down like this, and then the nose, this touches down. I may fall. Okay, this is really dangerous. Okay, okay. Please forgive that. Okay, this risking. Okay, that's okay, sir. So this is Simont maneuver. You go up and then you go down and then come up. Is that okay? That is Simont maneuver. Clear, everybody? Okay? Fine. For apply maneuver, how do you do the apply maneuver? I will show you. Okay? So again, 45 degrees to one side. You go down as much as possible, as much as the patient allows, go down like this. Then turn the head like this. Then again, take this hand, you keep it like this, and then roll over to this side. Is that okay? Then you make the person sit up with the head little turned down. Is that okay? This is what maneuver? A place maneuver. Okay. For Simont, I don't know. I'll just take the risk. Okay. Okay, fine. Okay. So in Simont maneuver, you do like this. You put the hand down. Okay. You usually use a low-lying couch. You go down like this and then look up 45 degrees. Is that okay? Then you go down and then touch. This again, the name has been given parieto-frontal by again Dr. Pradeep, because parietal eminence is lowest on this side, frontal eminence is lowest on this side. Is that okay? That is for Simont maneuver. So this is done. What is the next thing? Posterior canal over. Short arm posterior canal is called bow and yaw maneuver. I will show here, not on top of that. In bow and yaw maneuver, what you do? You keep these hands like this. You put the head like this, full down, and then 30 shakes. Okay? And then get up. That's all. This is bow and yaw maneuver. Okay? Is that clear, everybody? That is bow and yaw. You can make the bow and yaw little more sensitive by, after doing the 30 shakes, if you know which side is affected, just tilt the head like this to that side. Tilt like this. Ear to shoulder tilt. Is that fine? And hold it for 30 seconds. That's all. But that is not a must. Is that fine? That is the bow and yaw maneuver. Okay? This is for short term. What is left now? Anterior canal. So for anterior canal, we have the Ecovino maneuver. I'll show the Ecovino maneuver first. And then we have the Bangalore maneuver. Okay? Now most of the time we are doing only the Bangalore maneuver, but I'll just show for historical this thing, the Ecovino maneuver. So in Ecovino maneuver, you make the head like this as much as possible beyond the edge. Wait for 60 seconds. Then the chin touches 60 seconds. And then the person sits up. Is that okay? This is for anterior canal. But the other thing that we do more commonly now is what we call the Bangalore maneuver. In Bangalore maneuver, what you do? This is the most important. The thighs straight is very important. If you do this, it becomes difficult to get that position. Is that okay? But if you do this, it becomes easy to get that position. First, forehead touches, 1 minute. Then the vertex touches, 1 minute. Is that fine? Then you go back like this, 10 seconds, and then come back. Is that okay? Go back like this, 10 seconds, and then you come back like this, and then wait for another 1 minute. That's all. Then, to increase the success rate of a place maneuver, you can do something called praying before and saying thanks later. This was again presented in Barney Society by Dr. Pradeep. Okay, this was presented to a full hall. So what is this? In the posterior canal, there are debris there. You want to mobilize the debris. So what do you do? Before even you do the Dixalpike, look at God, ask for redemption, and if you think God rests above, we don't know which side God is. Okay. Then finally, once every maneuver, apply maneuver, everything is over, then look down, say thanks to God. This was presented in Barney Society to a full hall. These people were heroes this time in Barney Society. For the first time in so many years, it was the Indian papers which got the full halls in Barney Society this time. Okay? That was. Okay. So that is what happened. So many things. So these are all the maneuvers. Is that fine? Now I am around. You can. It is not about retest. What I do is I keep repeating the play, I keep repeating the barbecue roll, I keep repeating the Guffoni, whatever, till one maneuver is wasted. What is this concept of one maneuver wasted? If I do a play maneuver, I repeat the play again. First play, he got the nystagmus, everything. Second play, he's still getting the nystagmus, he's still getting the vertigo. That is not wasted. Some more debris moved, correct? I do one more time. That time he gets no symptoms. One wasted maneuver. Then I stop. I keep doing it till one maneuver is wasted. It is like that. This is the same thing. See, bronchial foreign body, how we are approaching. You go, you remove, you come. But you want to be sure there, no? No, this is what I am asking. What is Dick-Salpike? This is the concept I am covering. What is Dick-Salpike test? What is Epley maneuver? Same. See, Epley maneuver, first part of Epley maneuver is Dick-Salpike. So I am not stopping at Dick-Salpike. I will finish off. That is the only concept. Clear, sir?
Most of the people take those beta histamine and come. So what is the ideal time? That
Don't wait. Don't ask them to stop. If they have taken beta histamine and come, do it still. Why? This is a very, very different concept than what is generally taught or discussed. Okay, a lot of the things that we discuss is different actually. If a person is already taking a antivertiginous agent and he comes to you, two possibilities. One is he will not get the vertigo nystagmus. You repeat 2 or 3 times, he doesn't get, you call him. 3 days you stop and you come. But if the person gets the vertigo and the nystagmus, you got the diagnosis? Now the advantage of he being on this suppressant medications or whatever, anti-vertiginous medicines is that your therapeutic maneuver is going to be better tolerated by the patient. Why do you want to lose out on this opportunity? Why do you want to lose out on this opportunity? Everybody tells, no, you have to wait for 3 days, 7 days before you come. Nothing like that. Nothing. If you get it, do it. It is a good opportunity for you. If you don't get it, you always tell the patient. I tell my patients, see, generally like this has been, I've been following for last 1 year. I tell the patient, see, you are already on drugs. There's a possibility that I may not get it positive, but rarely it has happened that it has not come positive. Especially with newer tools. You get 2 nystagmus beats, it's enough to make a diagnosis. For me, how much ever nystagmus, when the head is moving, no significance. The moment head has stopped, even little bit of nystagmus is significant. Is that clear? Okay. So all these things are done. All the maneuvers are done. I want you to practice. I am around here. Okay? Fine. Can you see torsional? That was torsional. You want to see vertical? You saw the vertical? You saw the vertical? There you saw the horizontal? Okay? It is all about the clinician. You can have 30, 40, 50 lakh rotational chair and do, but you have one thing. You can have 1 0-degree endoscope or you can remove. It is the clinician. You can remove the pituitary, you can remove a prepontine mass or anything you can do. It is what matters is the clinician. We have made a tool. And this tool you can do. You have head movement, so much is there. You can do head impulse test with this. Okay, unfortunately, I am not able to show because my laptop has issues and this laptop has a little older version of the software. But I can show even head impulse you can do with this. Okay, and then correlate it with the head movement. Okay, so I will show that to you. Okay, see that. You saw that? You can do any canal. Okay? Okay? And now, with the other version of the graph, it is easy, but then, see the beauty here. Can you see that? With the head movement, the eye movement. But this was what? Can I have all of you for 2 minutes here, please? Can I have all of you for 2 minutes here, please? See, this is slow motion. Pradeep sir, just send them for 2 minutes, sir. All of them. Please come for 2 minutes. There is some table there. రాజశేఖర్ గారు వాళ్ళు ఏం చేస్తున్నారు అక్కడ?
certificates collect చేస్తాం.
ఓకే ఓకే ఫైన్. But just 2 minutes, send everybody, send everybody for 2 minutes. So now when you see this, you see I just recorded this right now. This is absolute slow motion. This is 1/4 speed. Can you see that? When I made the head movement, see. You saw the nystagmus? See? This is 4 times slow time. Then also it looks so fast. Where exactly when the head is moving, same time the eye is moving to the opposite side. Can you make out that? That means the vestibular reflex is functional. Otherwise it is not functional. You can do for vertical, horizontal, anything. See here now. This is, when the head is coming down, the eye is going up. When the head is coming down, the eye is going up. Can you see the sclera appearing? Okay. When the head is coming up, going up, the eyes are coming down. In time, that means this is perfect. Okay. You can actually correlate with the head graph and see the timing also. That also is possible. Okay. Unfortunately, my laptop has an issue. Okay. It is not just chargers, or so many other problems with that. Otherwise, I could have shown you that also. Is that clear? Okay, fine. So this is not just only so much. This is 1/4 recording. How this is possible? 1/4 0.25 is the speed at which I played. Why this is possible? Because for the first time we are recording 100 frames per second, 100 FPS each camera. So that is why all this is possible. Otherwise this would not have been possible. Is that okay? Then there is, see this. There is a fixation light. Can you see the light here? Okay. This light actually goes all the way inside. Can you see the red light here? This is an electronics free flap. We have 2 flaps, one for pupillometry and one for this thing. So what is this flap made of? This has optics here, which takes the light from here, converts any light into red color, and then it gives here. Okay, it brings out the light here and then it comes out. Is that okay? So this is how this does this thing. So there is a pupillometry protocol here. You have a protocol called pupillometry. I will show you the pupillometry protocol. This is pupillometry protocol. So what you see here, lights can come on. Okay. Okay. Can you see my pupils are bigger? Right? Okay, I'll just start the recording. This is, I think, older version. Okay. So can you see my eyes? The pupils have become big. Correct? Yeah. Can you see the pupils becoming small? Big and small. Okay. So this is the pupillometry protocol. When they were becoming small, you can see the graph going down like this. Okay. That is even better in the new software. Okay. That new software is in my laptop. My laptop has a crash issue. Okay. With this thing. So there are lights that is there. You can feel this flap. Okay. Okay. There are 2 such ones. Okay. One is for converting white light. Another is one. Can you get my device? Can you get my device? Sharath? లేదు నా డివైస్ కనెక్ట్ చేయలేదు ఇది ఇక్కడది నాట్ దట్ మై బ్యాగ్ మై డివైస్ బ్యాగ్ ఇస్ డిఫరెంట్ యా ప్లీజ్ బ్రింగ్ దట్ బ్యాగ్
He has incorporated premium quality rod lens into the visor. That shows the concept. The premium quality what you get in spot 0 degree finish. The rod lens has been incorporated into the visor.
So to make it electronics free, okay, so I will show that to you now. I am not very yeah. I reconnected that. Yeah. చేస్తానండి.
Like anyone who is really interested, pursuing further vestibular courses.
So I have a question for all of you. Yes, sir. Chappan, sir. Chappan, sir.
Before university course is there, it's a certified course. Those who want to really pursue further, take it further. Till now, 1,050 students have been.
All of you come please here. Please, please, everybody come here.
Biggest achievement considered by any measure. 1,050 neuroauthors, 3 years. Probably out of that at least you can get 30-40% of green.
Okay.
300 to 400 good neuroauthors to India. That's the master subject.
Okay. Can you see this light here? This is a white light. Okay. So there are two flaps. This flap, the moment I put, can you come closer and see what color light it is?
Red.
It has become red. Okay, the white light has become red here in this flap. I just changed the flap. Nothing. There is no red color anywhere here. This is my design. Okay, converting, color converting. See this. This is white. Can you see this white? This is for pupillometry. You can see the pupil becoming small with this. So in one device, we have pupillary assessment. In one device, we have head motion. We have 100 samples per second. Nobody across the globe has surpassed this quality. Next thing is, when you look at this device, you can see the thickness. This is not even a finger breadth. When you see this thickness, this is just 1 finger breadth. I want all of you to learn how to identify a good quality video nystagmography system. Everything else is like a bus stuck on the face. Why should it be like this? So this is very small. There is a glass here, there is a glass here, there is no glass here. You saw the quality of the eye video. This is next level quality. Okay. I don't consider this as a business venture. I don't consider this as a sales venture. For me, this is my gift to the community. This is exactly how I look at this. This is my gift. Okay. This is what we have done. Okay. To give to the community. So pupillometry in one, head tracking in one. If there is, today is more of a BPPV day. Today is more of a migraine day. So I didn't go deep into demonstrating this one. People who come for the Enopaya course, they went through the full process of full features of all these things that can be done here. You can do a head impulse with this, just with this. You can do chair rotations with this. You can do pupillometry with this. You can do saccades. You can do so much. You can do fine analysis, so much with one. It is like one tool, you can do so many beautiful things. Okay. Everybody else in the globe who has made a VNG system, even if they call themselves as the best, is a distant second. Not second, it's a distant second. Okay. This is the best device ever made. Love with love. This is the proof that India can make best quality product. I'll tell you what is happening here. You see the thing here. Can you see the camera here? This mirror-like thing is the camera. The mirror-like thing is the camera. This is the technology that I came up with many, many years ago. Okay, I can tell the exact story when I got the idea about doing this. This is called a daylight filter. I introduced daylight filter to remove artifacts in pupillary tracking, so that we get such beautiful tracking. You saw the graphs that were coming sawtooth so beautifully. That is all happening because of this technology. You know what? I introduced this 10 years ago. 10 years later, a company called Inventis sends an email to everybody telling our V-hit is now improved because we have introduced daylight filter. The days of we copying technology is over. They are copying our technology. That is the stage with which we have done. They used to put one LED light. I have taken the decision, why should we put LED light? Only they make Mercedes. That is why we put a rod lens into this. You take the light enters from here, it goes like this, it comes out. You can't even see the path.
Sir, when we were at Barani,
Yeah.
Professor David Z was asking, see nowadays cameras, what happens? Even though you look little dark, with the photography or with the cameras you are having and the apps filters you are having, you will look bright, right? So he is thinking that the graphs are like actually having filters and we are like...
We are doing artifacts to smoothen them up. That is what he was thinking. Because everywhere else in the globe, when you see these Western Johns Hopkins people, they are not that much of a graph people. They are more of a video people. The reason is they never got good quality graphs. When he saw our graph, he was like, is this filtered and smoothened? He told, no, there is no. Then immediately they called me from our team who was there. Okay, Dr. Sandeep Sharma was the one who was talking to him. He called me from there and he asked me, Srinivas, are you using a filter? I told, sir, 10 years ago, I took a conscious decision that I am not going to use a filter. The moment, oh, you didn't use a filter, still you got this kind of a graph. Now you show me the videos. This is the conversation. This is the kind of discussions that happen. These buggers, neuro equilibrium, they are writing, we eliminate filter, we eliminate blink and all those things. That is nonsense. You should not do that. You should not be doing that. And they can. Unfortunately, what happens, vertigo is so not so understood. So there are people, you go to a certain institute, they write, these are the specifications. They write the specification given by the manufacturer. Manufacturer writes this. This is like an advantage. Knobs, software adjustment of the goggle, all those things, that feature and all, they will write. My goggle does not need any adjustment. So like that and all, it is there. Unfortunately, but why I am taking this pain is, all of you should know how a goggle should be made, so that this bluff can be stopped. Second thing is, please, you have done this today. Did you all understand BPPV? Yes, easy? You understood? Please don't give up your brain for somebody from 1,000 kilometers. They will tell, I will put one device at your place, give me the place, 50% or all those things. Every time the diagnosis is wrong. Why? It is right because statistical probability of something coming right is because there are some 10 diagnoses. Statistically, mix match will happen. Like it is writing D for all the NEET questions, still you will get some mark. Like that it will happen. The reason is, a person who does not know about the patient, how they can find out? When they go up like this, you get a nystagmus. They are seeing only the video on the graph. The graph will think that it is posterior canal BP, lateral canal BPPV. There's a paper coming, 46%. Why they are 46%? Because per positional nystagmus, they are calling it as positional. All this nonsense is happening. I am opening my mouth. I know what is, it is getting recorded, whatever it goes also. They can't touch me. Because what I am talking is the truth. What I am talking is the truth. This is one level. There is another level of fraudgery that is happening. Photoshopping, that's another thing, okay? That I don't want to even talk, okay? That is another thing, okay? Yeah.
See, there are two things.